Started. I'd like to call the eighth meeting of the House Standing Health Service Committee on Health Services to order. Please silence your cell phones if you don't mind. And DJ, please take the roll.
Representative Bratcher. Representative Bray. Representative Burke.
Here.
Representative Callaway.
Present.
Representative Camuel.
Here.
Representative Dotson. Representative Fleming.
Present.
Representative Gordon. Representative Holloway.
Here.
Representative Marzian. Representative Neighbors.
Here.
Representative Proctor.
Present.
Representative Rayburn.
Here.
Representative Raymer.
Here.
Representative Riley. Representative Sharp. Vice Chair Duval.
Here.
Ranking Minority Member Wilner.
Here.
Chair Mosier.
I'm here. Okay. We have a quorum established to do business, so I'd like to welcome everyone to this meeting and thank you for your attention to these important issues. Do we have any members who would like to introduce any guests? Okay. I think that just means that you're all welcome, and thanks again for being here. Okay, we are going to go a little bit out of order. We have a request for House Bill 689 to go first. So Representative Neighbors, if you could make your way to the table, please introduce yourself and any guest and proceed.
Thank you, Chair Moser. My name is Amy Neighbors. I'm the state representative for House District 21.
And I'm Dr.
Thank you. I'm Dr. Heidi Murley. I'm here on behalf of St. Elizabeth Healthcare.
I'm Ross Rinaldo. I'm the CFO of Owensboro Health.
Well, welcome. I didn't realize that you were here, Dr. Murley. It's nice to see you.
It's good to see you as well.
Thank you. All right. You all go ahead with your testimony.
All right. Chair and members of the committee, thank you for the opportunity to present to you today House Bill 689. House Bill 689 provides the statutory authority for Kentucky to implement a Medicaid state-directed payment program for physician and non-physician professional services delivered through qualifying hospital-affiliated groups. This bill directs the Department for Medicaid Services to seek approval from CMS and, upon approval, to implement the program beginning January the 1st, 2026, with retroactive payments for that calendar year. The goal is simple: strengthen access to care for Medicaid patients, especially in rural and underserved communities, while supporting physician workforce retention and aligning reimbursement with quality outcomes. Right now, many physicians and non-physician practitioners affiliated with teaching hospitals are not eligible for existing state-directed payment programs. That creates a funding gap, particularly for providers caring for large Medicaid populations. House Bill 689 allows Kentucky to use an existing federal mechanism to help close that gap. This program is estimated to generate approximately $29 million per year in new federal Medicaid dollars by allowing the qualifying hospitals to receive enhanced Medicaid payments for professional services which they currently do not. Importantly, it does not require general fund revenue. Payments would comply with federal law and would increase Medicaid reimbursement up to the Medicare rate. Participating providers would also be required to meet state-identified quality metrics consistent with our existing programs. This legislation is about access, stability, and workforce support. It leverages federal dollars, strengthens our healthcare infrastructure, and supports the providers who care for some of Kentucky's most vulnerable citizens. At this time, I would like to
We have a motion and a second. We will have some questions, but I'd like to offer you the opportunity to continue speaking if you'd like.
Unless Mr. Rinaldo or Dr. Murley have any additional comments.
Okay, we'll take questions.
Okay.
Okay.
we're-
Happy to take questions.
Okay, we will go to questions. Representative Marzian.
Thank you, Madam Chair. I was just going to say, I'd like to hear their testimony since they've come all the way to Frankfurt. I think this is an important bill, if y'all don't mind.
Sure, absolutely. Like I said, I'm Russ Renall. I'm the CFO at Owensboro Health. We're a rural health system. We have 3 hospitals. Our flagship is a Soul Community Hospital, and our 2 smaller hospitals in Muhlenberg and Grayson County are Medicare low volume and Medicare dependent. And so I say that because access is pretty important to us. A lot of times in our community, we're the only place that our residents can get health care. And so we take that those designations pretty seriously. We want to have access. And one of the hardest places is physicians. Getting physicians to a rural area, there's a shortage of physicians. It's very hard, and it requires subsidies. We've had to increase our subsidies over the past decade by millions of dollars in order to continue to serve and keep access. And while that's happening, on the payment side, Medicare fee schedule has actually been reduced. So while I'm paying subsidies for physicians, the Medicare fee schedule that's supposed to cover their salaries, their practice expense, and their malpractice has actually reduced by 7.5% since 2020. But my salaries keep going up. I'm not paying doctors less. Supplies keep going up. So this allows us to continue our access efforts. We've put specialists, primary care in those rural counties, and just this past year we made efforts. We had a couple OBs that retired down in Grayson County, but we wanted to keep OB services for that county, so we made efforts and increased our subsidies there to continue that service. So it's like Representative Neighbors said, it doesn't cost the state any general funds. It meets the big beautiful bill criteria, and it allows us to improve quality and chase quality on our physician practices, but it also allows us to continue that access in our rural areas. So I appreciate very much the consideration.
I will also echo the concerns that we have about the market for physician and provider compensation to allow us to hire and maintain appropriately trained medical staff. St. Elizabeth has 3 acute care hospitals in northern Kentucky and a critical access hospital in Grant County, and we depend on government funding. Probably 70% of our payment comes from either Medicare or Medicaid, and that doesn't cover the cost that we incur with our providers and other things. So we are interested in having additional funding from the federal government to help us care for Medicaid patients. We are the primary care provider for Medicaid in our entire region. We have about a 16-ish% Medicaid overall. We also have outstanding quality and patient experience through our medical group. Those patients who are attributed to one of our St. Elizabeth providers as primary care have significantly lower utilization of ED and inpatient services and better health metrics. So we are very interested in continuing to serve our entire community, including all of our Medicaid patients, with screening, outreach, things that we just won't be able to continue doing if we don't have an appropriate source of funding to care for those patients.
Okay. Do you have another question, Representative? Go right ahead.
Thank you. Thank you for your dedication. I really appreciate that. My question is, you said $29 million coming from the federal government, which I really like accessing that, and no general fund money, but won't it be the 30% match from the state for the Medicaid money?
The match comes from the the university partners.
Okay.
So we are affiliated, St. Elizabeth is an affiliation with University of Kentucky. Some
Okay.
of the other folks, including, I believe,
So we're with University of Louisville.
Yeah.
We have a school of nursing program in Owensboro, a BSN
Right.
program that's attached within the hospital that the university runs, and we help subsidize. We also have a family medicine residency in Owensboro that the U of
Right.
L and we subsidize and pay for. We want to expand both of those. We've talked about that. We've also talked about looking at expanding primary care with mental health and possibly dental services in our area, all of which is needed.
Oh, great. Thank you. Thank you. Thank you. That's
so
great.
those educational institutions, UK and U of L, will provide that additional funding.
Excellent. Can I have just one follow-up, Madam? Thank
One
you.
more.
Thank you, one more. So this will bring some funds that are desperately needed. So you'll also be seeing outpatients and clinics for wellness care, preventative care as well. So
Absolutely.
you have clinics set up as well as the hospital care that's so necessary.
Yes, ma'am.
And when we look at the quality metrics that are associated with this program, it looks at breast cancer screening, colon cancer screening, tobacco use, screening for clinical depression, diabetes care, controlling hypertension, statin therapy for patients with cardiovascular disease, BMI screening and follow-up, medication reconciliation post-discharge, opioid stewardship, well child visits, screening for depression, and obesity care. So these are all things that we will be continuing. We provide this care currently. This will help us continue to be able to do that sustainably for our Medicaid population.
Excellent. Thank you, Madam Chair.
Of course.
I'm done.
Thank you. Representative Camuel.
Actually, you just answered my question, so we're good. Thank you.
Excellent.
Okay. All right. Representative Callaway.
Thank you. I just had one question. This is specifically for practices that are associated with hospitals and teaching hospitals, even more specifically. So this is not for private practices at all. Is that funding available to those practices and we're just not setting up that payment process, or is this not available to them straight from the federal government at all?
This particular program is affiliated with our university programs and teaching hospitals. So it doesn't preclude other organizations from joining if they meet those criteria. But I don't know would have a mechanism to have a private practice affiliate through it.
Can I just follow up? I'm still not clear. So federally, the money is available if they have their own agent to access it. Is that what you're saying? Or is this program federally not intended for the private practices?
I think I can answer that. I mean, unless you.
Go ahead.
Okay. So this is a program that was established under H.R. 1 to allow DMS, our Department of Medicaid Services, to apply to CMS for a special program I think it is specific to only a small fraction of hospitals who are training hospitals.
Yes.
Right.
Yes.
Okay. So, I mean, it would benefit the providers within those hospitals, but those providers aren't getting direct funds from this program. Is that correct?
Yes.
Okay.
Thank you,
that
Representative
help?
Mosher.
Okay. All right. Thanks. Okay. And Representative Fleming.
Thank you, Madam Chair. Doctor, you mentioned 70% of the revenues are for Medicaid and Medicare. Is that correct?
Yeah,
And then
that's our organization.
for all three facilities?
Overall,
for
yes,
overall?
overall. For inpatient care, about 60% government payer for outpatient care.
Okay. And then you said 16% of Medicaid. Is that part? I guess explain that. Is that a subset of the 70 or is that overall?
That's overall. So overall, our patient population is about 16% Medicaid.
Okay. All righty. And looking down the road, a couple years down the road, there's other things going to be hitting hospitals. How are y'all preparing for that?
That is a great question. So as most people understand, some of the Medicaid supplemental payment programs like the Hospital Rate Improvement Program, HRIP, will be decreased from the average commercial rate down to Medicare, which will have a significant impact on our health system and others over time. That's scheduled to start happening within the next year or so, and then will escalate over time down to the Medicare rate. We currently don't cover our cost with Medicare reimbursement, so this just is going to compound the problem. And we should note that this allows for Medicaid patients to be reimbursed, their care to be reimbursed at the Medicare rate. It's still not going to cover our cost for a lot of things, but it will help close that gap.
Okay, all right, thank you. Thank you, Madam Chair.
Okay. We'll see no further questions. We have a motion and a second on the bill. DJ, please take the roll.
Representative Bratcher. Representative Bray. Representative Burke.
Yes.
Representative Callaway.
Aye.
Representative Camuel.
Yes.
Representative Dotson. Representative Fleming. Representative Gordon. Representative Holloway.
Yes.
Representative Marzian. Representative Neighbors.
Yes.
Representative Proctor.
Yes.
Representative Rayburn.
Yes.
Representative Raymer.
Yes.
Representative Riley. Representative Sharp.
Aye.
Vice Chair Duvall.
Yes.
Ranking Minority Member Wilner.
Yes.
Chair Mosier.
Yes. Oops. House Bill 689 passes with favorable expression. The same should pass on the House floor. Congratulations and thanks for coming, of course. Okay.
Kim. Are you going to announce this can go prefer to Moab? It won't slow down the process, but I don't know.
Okay, just for members' information, House Bill 689 will also go through Moab just for further discussion and clarification on Monday. But it doesn't change the fact that this passed today. Okay, next we will take up House Bill 407. Representative Proctor, if you can make your way to the table and please bring any guests with you, introduce yourselves for the record, and proceed with your testimony.
Thank you, Madam Chair and members of the committee for the opportunity to present today. I am Mary Ann Proctor. I represent the 60th District in Boone County, and I will have my guests introduce themselves.
Thank you, Madam Chair, members. I'm Colleen Lindgren, Senior State Policy Manager with the Pacific Legal Foundation.
And my name is Chad Reese. I'm Senior Policy Advisor with the Institute for Justice.
Okay, before we get started, we do have a committee substitute. We have a motion and a second. All in favor, please indicate by saying aye.
Aye.
Any opposed? Okay. Please proceed with your testimony on the committee substitute.
Okay, on the committee sub, all we've done after this bill came out, there were some concerns about some of the language in here. So what we did is we met with people that were concerned. And so if you look on section 1 on page 4, we added number 4, and it basically just instructs the cabinet that they must establish a policy to reach out to the dominant provider if they need that information to be able to get the data that they need to make a determination on certificate of need. That's all it does. Okay. We just want to start off with a brief history on why we need House Bill 407. In 1972, the state of Kentucky instituted Certificate of Need, and we use a lot of acronyms in this committee, so from here on out it's going to just be CON, is how it's commonly known. And in that time, what the government was doing was artificially reducing the amount of beds, healthcare providers, because they were worried about increasing healthcare costs, about duplication of services and quality. In 1974, the federal government did the same thing. They nationalized CON, and they did it to be able to receive certain federal fundings to the states. However, the federal government realized this was not accomplishing the purposes, which was to contain costs, to make more accessible, and to improve quality. And in 1986, CON was repealed. Many states went ahead and followed that, including our neighbors to the north, Ohio and Indiana, that only have one CON, and that's for long-term care. However, Kentucky has fundamentally not changed any of the processes of CON since 1972. The fundamental structure still exists. So what this bill seeks to do is streamline the process of CON. That's all it does. It does not repeal certificate of need. It streamlines the process, and I will have my colleague explain about that a little bit more.
Thank you, Madam Chair, members of the committee. As I said, my name is Colleen Lindgren. I'm with the Pacific Legal Foundation, and we're a nonprofit public interest law firm that has represented clients free of charge in courtrooms on a variety of constitutional cases, including healthcare opportunity issues like the laws that we're discussing today. And in my role, I'm really lucky because I get to work with legislators like you who want to proactively help their constituents and make better law. And so, as Representative Proctor mentioned, these laws have been on the books for a long time, and every presidential administration since Ronald Reagan has recommended repeal of CON. And most notably, I think the current administration has made their opinion very clear about certificate of need by including it as a piece of their Rural Health Transformation Fund criteria. This is an issue that's coming up all across the country. Relatedly, just this week, Iowa, which in its Rural Health Transformation application indicated that it was going to start working on CON reform, followed through on that by passing through both chambers a pretty significant reform. And there are many other states that are considering similar things. And so I think Kentucky's really in line with this vision for more opportunity in healthcare, and couldn't come at a better time. And I think that this 407 is a really great step, as Representative Proctor mentioned.
Okay, we have a motion and a second. Would you like to proceed?
No, ma'am.
Okay. Well, I will call up Mark Guilfoyle, who has signed up to speak on the bill. And if you all could either make room for him or step back for a minute or so, stay nearby for questions. And welcome, Mark. Thank you for being here with us.
Thank you, Madam Chair.
Make
Good to
sure your
see you.
microphone is on, the green light's
Looks like
on.
it's
And
green. I'll move it up a little bit.
Yeah,
How's that?
okay.
Can you hear me?
Just introduce yourself for the record, please.
Yes, my name is Mark Guilfoyle. I'm a lawyer from Northern Kentucky, and I'm here.
I don't know, is your light on?
It is now.
There you go.
It's bright green now. Thank you. So I am Mark Guilfoyle. I'm a lawyer from Northern Kentucky, and I'm here representing St. Elizabeth Healthcare, which you just heard Dr. Murley say that we have 4 hospitals in Boone, Kenton, Campbell, and Grant counties. And I'm here to speak in opposition to House Bill 407. And I'm doing that with a background of representing hospitals all over the state for many years in certificate of need cases, both for and against opposing applications that were pending. So I'm trying to give you a little bit of my experience, number one, but also really talk about Northern Kentucky. Because there's a lot of things that are talked about that are broad strokes that I think everyone needs to have a baseline understanding on. First of all, in Northern Kentucky, Northern Kentuckians have choice. St. Elizabeth is not a monopoly. You hear that talked about sometimes. In Greater Cincinnati, there are 19 hospitals. And that's the market in which our patients access care. By comparison, there are 8 hospitals in Greater Louisville, and there are 5 in Lexington Metro. So we have 19. In Northern Kentucky, 60,000 Northern Kentuckians cross the bridges every day to go to work in Cincinnati. So we have a situation where on both sides of the river, Ohioans, Kentuckians, we cross that Ohio River every day for entertainment, for work, and for health care. So a lot of Northern Kentuckians go to Cincinnati hospitals. A lot of Cincinnatians come over to St. Elizabeth. So that river is really not a barrier to accessing care. And most importantly, 95% of health care is delivered in office or outpatient care settings. So physician offices in most outpatient facilities do not require a CON. That's 95% of the health care that's being delivered, not just in Northern Kentucky, but all over the state. As of March 2026, currently, there are 123 CON-approved healthcare services in Northern Kentucky. 123, but only 23 of those are held by St. Elizabeth. The second point I want to make is that there is no such thing as a competitor's veto. You might have heard that term bandied about. So CON is not a barrier to care in Northern Kentucky. Since 2015, 75 CON applications were filed by providers in Boone, Kenton, and Campbell counties. And of those 75, only 3 were denied. And that's on par with the statewide average approval rate of 94%. Since 2015, St. Elizabeth has only opposed 1 Certificate of Need application in Northern Kentucky. The last point I'll make, and I'll be quick, we think that this bill will do damage to the Certificate of Need process. And what that will do in particular to St. Elizabeth is it will harm safety net hospitals. So St. Elizabeth in Northern Kentucky, we are the safety net hospital. And by that I mean we provide a high volume of low-income, uninsured, and publicly insured patients regardless of their ability to pay. Now, our competitors in the greater Cincinnati market, at least 3 of them, they are not safety net hospitals. And if they venture into Northern Kentucky, as they have, not for hospitals, but for several other facilities, they're not required to take low-income, uninsured, Medicaid. But we take care of those people, and that's why this bill is so important to us to oppose. Let me just say a few things about the bill itself, Madam Chair. There's no question that Certificate of Need survives this bill if it passes. But what we're concerned about is that CON will really become kind of a shell of its former self if it passes. And I'd like to point out 3 things. On page 5, section 3.1, there's an amendment that you can see there where the ability to request a public hearing is taken away from something called an affected person and given only to the applicant. The way things work currently under Certificate of Need law is that when somebody files an application, it goes on public notice, and an affected person can look at it and see it, and if they're opposed, request a public hearing. That's how you oppose an application. That right to request a hearing is now being given only to the applicant for CON. And our concern is, why would an applicant ever request a hearing to oppose its own application? That seems to be a little inconsistent. The other point that I'll make is at the top of the next page on page 6, that makes it very clear that only the applicant can present evidence. It's taken away from parties to the proceeding. So no one other than the applicant is going to be allowed to present evidence at a hearing. And that will effectively result in a 100% approval rate. No CON application will ever be denied. And that will surely lead to a proliferation of healthcare services, something that the CON law in its statement of legislative findings, which is in 216B.010, says we're guarding against proliferation of services that are not needed because that results in costly duplication. This bill won't change that statement of findings, so there's a basic inconsistency there. Finally, Madam Chair, I'll point out on page 10, section 6, subsection 1, it's very clear that only an applicant will be able to appeal a CON decision to court. So again, this bill deprives affected persons of that ability, and it really puts the applicant in the driver's seat to be the only one to really control the process, and we think that's going to lead to, you're going to get a CON every time you file for one, and we don't think that's right. Thank you.
Thank you very much for being here. Thanks for that information. Before you go, you referenced page 10 and subsection 1 about the appeal process.
Right.
So this would preclude any incumbent entity from filing a suit or challenging the application at all?
Yes, ma'am, that's how I read it, because the words that are stricken through are any party to the proceeding. That would have been the incumbent provider, typically. So if it's only the applicant who can file the appeal, the incumbent provider will be shut out of that process.
Okay, so if the final judgment is something that the incumbent facility wishes to challenge in a civil action or the court of law,
Yes.
they are not allowed to do that. Is that what you're saying?
Under this legislative framework, absolutely, that is correct. There is always the possibility that a hospital could file a lawsuit under Section 2 of the Constitution,
Right.
claiming that it was arbitrary action by the government. That is a very high bar. It's very hard to prove. And if the cabinet kind of abides by its regulations and doesn't violate 216B, you won't have any chance of winning a case like that. But under the CON law, you don't have that direct appeal right that we typically have now.
Okay, all right. Thank you for that clarification. Okay, do we have any questions? Representative Bratcher.
Yes, sir. I appreciate your sharing the information, but under the Institute of Accountability Care, you defined that St. Elizabeth was a safety net hospital, but I didn't find their name on that. So I just was wondering why they're not listed on there as a safety net hospital.
Yes, sir. I'm not familiar with that particular registry, whatever it is. I will tell you that if you Google safety net hospital, you'll find there's no accepted definition. It's not defined anywhere. But I think practically and typically it's defined as a hospital that provides a safety net for low-income, uninsured, underinsured people. And St. Elizabeth meets that definition because we're a nonprofit Catholic hospital, and it's part of our mission to care for everybody who comes to us.
So you're self-proclaiming that you're a safety net hospital, correct?
I will agree with that. Yes, sir. I will agree with that. And I think it'd be hard to contradict that. But yeah, it's something we're very proud of. It's part of our mission.
Okay. Representative Marzian, do you have a question?
I do, Madam Chair. Thank you. And thank you for your testimony. So would you say that this bill would lead to kind of, I don't want to say unfettered, but increased facilities, machines being built and a little bit of waste, fraud, and abuse with this?
Thank you, Representative Marzian. I would not say waste, fraud, and abuse at all. What I would say is just the way the structure is here. If somebody wants to build a new radiation therapy program that duplicates the one that's right across the street, they'll file for an application. They won't request a hearing because they don't want to oppose their own application, and they're going to get a CON. So anybody who asks for a new facility or a new service is practically guaranteed to get it under this bill, but I don't consider that to be fraudulent or wasteful in terms of how those words are used. I'll just use the experience right across the river in Cincinnati. Right. Representative Marzian is correct. There is no CON over there for acute care hospitals, but boy, if you go over there and look at their facilities, there's three on a corner, every corner. It's some
duplicative,
very duplicative, and I think you see the costs in Ohio are much higher than they are in Kentucky. I think it's partly a result of that.
Thank you,
Representative Callaway.
I actually had a question for the bill sponsor.
Okay, thank you.
Thank you, Madam Chair.
Of course.
Thank you. So we heard the concerns about the applicant being the only one that could bring materials. Does your committee sub address that at all? I feel like requiring them to establish a procedure to reach out. Does that address that?
Yes, that's what the committee sub is designed to address. So currently, Mr. Guilfoyle is correct. The statute confers a right to applicants or to non-applicants, and or the affected party is the term there. And what that does is really tilt the scales towards them in favor, like against an applicant. And so all that we're trying to do here is make sure that the process that the cabinet has, that the state of Kentucky has approved, is thorough and is fair. And so the committee sub ensures that the cabinet has a process to get necessary information from existing certificate of need holders and anybody else that is relevant to their decision-making process. But it also ensures that nobody has the right to interfere with an application, which, as was already discussed, is used against them in current administrative hearings, but also can be used against them in court. And it's really an unconstitutional right that the statute is currently conferring upon other parties.
Thank you.
Okay, all right, thank you. Well, seeing no further questions, I want to thank the bill sponsor for your work on the committee substitute. I felt like requiring the cabinet to establish a process to gather any information from the affected party, the incumbent facility, was ensuring that the information that they would have provided on their own is part of the initial hearing, and the cabinet is required to promulgate regs, and so they can still factor in the need for perhaps additional information. I am a little bit concerned about the issue having to do with an appeal, but maybe that's a discussion that we can have in the future. But I don't. Oh, Representative Fleming, you snuck in there.
Sorry about that.
No worries.
Representative Proctor, I would ask your guest a question if you don't mind. You're a knowledgeable woman. I know you are, but let me ask her. She had a little bit of background. Certificate of needs basically came back in sometime in the 60s in terms of addressing rising costs and so forth. And then basically it was repealed or on a federal level to get rid of the mandates, but a lot of states still have that. And the gentleman who spoke before you, who's against this, he mentioned about rising costs over in not Indiana, geez, in the wrong part, in Ohio, in order that and I know there's the thought of having competition, and competition is good and so forth. Mm-hmm. Can you address what he said in terms of the rising cost and I know there's some folks that like to get rid of certificate of need totally across the board, and then some people want to keep it in place. Could you shed a little bit of light about that?
I can certainly try, and I think my colleague or my friend from IJ might have a couple comments too, but I would just say quickly, there are dozens of studies that have been done in the last few decades looking at certificate of need, and what we don't see is rising actual cost to the consumer. Now, of course, there are all different kinds of costs in healthcare that you can compare, and I have links to data I'd be happy to send you or follow up in a conversation. But what we actually see in South Carolina is actually a really good comparison, because it's something recent that we're all familiar with, is that the cost has gone down for folks in South Carolina under their certificate of need repeal that they did a few years back, and it's about estimated about $2,000 a year for individuals or households there. And so I think there are about 40% of states that don't have certificate of need or have it for a very limited service. And we just have not seen costs blowing up. Now, there are, as I said, there are different costs that can be compared between states. So, but cost to consumer and to the patient, which I think is the thing that most everyone is concerned about, we just aren't seeing it skyrocket in places that have let it go. And many places have done this for decades.
I think that was well put. And the only thing I would add to that is that the Institute for Justice has commissioned a couple of studies on this issue, and I'll be happy to forward those to you after the hearing's complete. Certificate of need is one of the most studied issues in economic policy that has one of the clearest outcomes. So the best way to look at these things, as Kylie noted, is that you might be able to pick and choose one example here and there. But if you look at what are called meta studies, or essentially taking all the studies in a field that have been compiled and try to say, okay, what do we find when these changes take place? The evidence is overwhelming that reducing or streamlining certificate of need laws overwhelmingly reduces costs for the consumer and increases access as well.
And I'll be very quick, Madam Chair. Cost is one thing. Also, another point is utilization. And utilization really spans across the spectrum of all services that are provided. What does that do in terms of utilization of the services? I guess, and from your experience, when it comes to not having a certificate of need.
Let's see.
I'm not sure I follow the question. Or is the concern about sort of unused health services that are established and then don't have patients?
Yeah, but what I'm going down the path like a certificate of needs. Let's take an example. Like let's do away with certificate of needs across the board. Okay, then you have competition. Then you have I'll provide this service. Across the streets providing that service. Then you got to look at the utilization. Access of care seems to be under that scenario is getting better, but is the utilization of that particular service being utilized? Is it going to be utilized as a higher utilization because more people are getting access to it? That's sort of my line of thinking. Hope I'm not way off base here, but that's what I'm thinking.
So I think if I understand your question correctly, you're saying, are we concerned that there will be more services and no one using them, or there's not enough people to use those services? Is that correct?
Part of it, yes. Part of it. Yeah, I mean, because if you have a bunch of services all in one particular corner or one particular block, but it's maybe sort of focused on accessibility. That's an issue. But then again, it comes back to profitability and making sure you're sustainable of it having a hospital and so forth in order to do that. So if you spread that, your costs and so forth is going to be a little more subjected in terms of your sustainability in terms of y'all basically being there. Not you all, but the facility being there. That's where I'm trying to go towards.
Sure. So I think one of the places that this concern has come up more often across states that I've seen is related to rural areas, just because of distance and population and whatnot. And in the last 20 years, there are 5 states that have been studied that don't have certificate of need for rural hospitals, and those are Colorado, Idaho, Oregon, Utah, and Wyoming. And they have had 0 closures since they did away with their laws. And there's other data out there, but I think that's a good example of how this isn't certainly an effort to close hospitals. I actually think when you're looking at certificate of need and across the board of different reforms, what we're really trying to do is equip both existing providers and new providers to be able to offer the services that are needed and wanted at the time. And those things do change, right? Demographics change, populations change. So what I'm really hopeful that this effort, starting with this really great reform in 407, is it's evening the playing field. And Mr. Giflow mentioned that all applications or all hearings requested for applications are to oppose. And I think that gets to the heart of the problem here, because there is an incentive currently to oppose a change or a new application. And what we want to do is open that up, and we want to open it up for everybody. And this is a really great first step to do that. And so as Chad said, we'd be happy to follow up with some more data and maybe dig in on a little bit of your concerns more specifically, or if there are things in your district you'd like to chat about. But across the board, my colleagues who've been looking at this for the last 10 to 20 years have not seen services go down or have to close, but what we've really seen is that services are able to adapt more easily and change, which I think is what we all want. We want patients to have more healthcare. Patients never say we don't want more healthcare in our area, but there is an incentive for current providers and to do that, and I think that's a difficult situation that to have that in statute, and I think that this bill fixes that problem and makes sure the state is just treating everybody equally.
Okay, great. Thank you.
All right, thank you very much. My only final comment is, that I would like to just continue looking at the funding streams and some of the states who have maybe made this change and see how this changed their application process and the approval process, and also look at the cost, the potential funding streams. it's difficult because healthcare is not really a free market enterprise. It's not like going to the corner store and buying the same apples in each store. The negotiated rates for insurance are different. The Medicare, Medicaid, and then we just heard about directed payments, and we have all of these subsidies that come in and help hospitals. So, I know that there are strict guidelines around things like state directed payments and 340B and those sorts of things that are funding streams for certain hospitals. I just want to make sure that we're not driving up the cost of healthcare. We need to improve access, of course. We need to maintain quality, of course. We need to maintain credentialing and all of the things that factor into this. But I just want to make sure that we're not driving up the cost of healthcare. So I appreciate this discussion, and we don't have any further questions. So DJ, please take the roll.
Representative Bratcher, Representative Bray, Representative Burke.
I'd like to explain my vote, please. I'd like to thank the sponsor for the work on this bill because I agree that this needs to be changed. The problem I have with the substitute is that for me, the meaningful input that you've included at the beginning of the process by encouraging the cabinet to have a procedure by which they gather that information, for my mind, doesn't substitute for the right of appeal. And when a corporation or a hospital, whether they're for-profit or not-for-profit, is directly impacted by a decision of the government, they need a right of appeal because the government's not always right. So I want to get this across the line, and I hope that we could look at making some adjustments so that I could become a yes, but today I'm a no.
Representative Callaway,
Aye.
Representative Camuel,
May I explain my vote?
Yes.
Thank you. Thank you for bringing the bill as well. And like my colleague, Rep. Burke, today I am a no for very similar reasons. As I'm reading the committee sub, everything about the bill yesterday was great. Reading the committee sub today, and the included language does not read as a way that creates that, like a safety net for individuals or for public hearings. It feels very one-directional and like just an administrative procedure that doesn't do what I think you may think it does. So today I'm a no. If that language comes out, it would be easy to get to a yes. Thank you.
Representative Dotson, Representative Fleming,
Aye.
Representative Gordon, Representative Holloway,
Yes.
Representative Marzian, Representative Neighbors,
Explain my vote, please.
Yes.
I've shared this with Representative Proctor. Because of my background in the long-term care industry, I do have concerns about how this could potentially harm our nursing homes across the state. So I'll have to be a no today.
Representative Proctor,
Yes.
Representative Rayburn,
Yes.
Representative Raymer,
Yes.
Representative Riley, Representative Sharp,
Explain my vote. I was going to be a no on this, but after the committee sub, I need to talk to the hospitals in my district. I'm going to pass on this one.
Vice Chair Duvall,
Yes.
Ranking Minority Member Wilner,
Explain my vote.
Yes, ma'am.
Thank you. I think we do need to reform CON. I do have some concerns here too, so I'm torn. So I'm going to pass for today.
Chair Mosier.
I will explain my vote in that I would like to address the appeal process in the legal representation piece of this, but I am a yes. All right. Okay. House Bill 407 passes with favorable expression. Congratulations, and thank you for your work on this.
Thank you, Madam Chair.
Okay. Next, I would like to, is Representative Nemus here? I don't want to hold you up. Yes, there you go. All right. Since you probably have better things to do than hang out in health services, I will bring you to the table to discuss House Bill 713. And if you have any guests,
I think
have
Miss,
them join you, or,
I think April Hester's online.
okay.
And for
very
the
well.
record, while she's coming on, I don't have anything better to do than to spend it with
Oh,
you
okay.
guys.
Well, thank you.
I've got other
I
things on the
appreciate your
calendar,
being
but
here.
nothing more important.
Yeah, we love having lawyers here. We do. All right. Okay, just introduce yourself for the record, please, and proceed.
Jason Nemus, House District 33. That's Jefferson, Oldham, and Shelby counties. April.
And I am April Hester. I am representing the Kentucky Nurses Association today.
Welcome. Thank you for being here.
Thank you, Madam Chairwoman. So this bill is to ensure that we are combating workplace violence in our facilities where healthcare is delivered. And so I'll ask Ms. Hester to have some remarks, and then I'll go through the two most important parts of the bill.
Okay, thank you.
Madam Chair and members of the committee, first of all, I'd like to take a moment to say thank you for the opportunity to testify remotely today. Again, my name is April Hester. I'm a certified registered nurse anesthetist, and I am here representing the Kentucky Nurses Association. I appreciate your time and your attention to this issue that directly impacts the safety of all healthcare workers, whether you work in a hospital, long-term care facility, or a physician's office, and that's workplace violence. Workplace violence in healthcare, in the healthcare setting, is real. It's increasing, and it's affecting workforce retention in the Commonwealth. A recent nationwide study found that over 80% of nurses experienced at least one type of workplace violence in the past year, whether it be verbal threats, physical harm, or intimidation, for doing nothing more than taking care of patients in the Commonwealth. 63% of medical providers report injuries from violence attacks in the workplace. Since 2020, those incidents have escalated significantly, with healthcare workers being 5 times more likely to experience workplace violence than any other profession. If we are serious about stabilizing and retaining our healthcare workforce, we must address the safety issue. A safe work environment is not optional. It's fundamental. It's foundational. Workplace violence should never be considered part of the job. When healthcare workers feel unsafe, they leave. When they leave, access to care suffers. Protecting healthcare workers in this state protects patients and strengthens the entire healthcare workforce system in the state. We are aware of no opposition to this bill, and we have worked hand in hand with the Kentucky Hospital Association on this. I respectfully ask for your support of this bill for the protection of not only nurses, but the entirety of the healthcare workforce in this state. Thank you.
Okay, we have a motion and a second, and I just want to thank April for your remarks and for your work on this issue. As a fellow nurse, I completely agree with you. We do have a committee substitute, and I know that that's what has been part of this discussion. We'll go ahead and before we actually can accept a motion and a second on the bill, we need to
Second.
Thank you. Adopt the committee sub. So all in favor, please say aye.
Aye.
Any opposed? Okay, so the substitute is adopted, and if you have any remarks on the substitute, I entertain your.
I heard a motion in a second. My
Okay.
mama didn't raise no fool.
Okay. Do we have any questions? Okay, Representative Wilner.
Thank you for bringing this bill, and thank you to April for testifying. I'm just curious, I'm for this bill, but I'm just curious if either of you, Rep. Nemus or April, have a thought about why we've seen this increase, and if you have thoughts about how to prevent it on the front end.
You know, I have thought about this, and this was a question that I was thinking about last night. I think truly it's fundamental, but It seems as though post-COVID things have escalated, and I don't know the reasoning why. I wish I had that answer for you because if I did, we'd have a solution to the workplace violence. But I do not know the reason before this. I don't. I wished I did. Otherwise, I would have a solution.
Representative Wilner, I don't know the answer either. I understand from my friends like April and others that it is increasing. I would think it's just a matter of sociology or psychology that when you are in a very traumatic situation, obviously, which a lot of people in hospitals are, they are more likely to do things they wouldn't normally do, perhaps. And I think maybe the rules don't mean as much when you're in pain, maybe when a loved one might be harmed, or maybe even yourself. And so maybe that's the reason. And I think that's more of a reason for us to make sure that we're protecting our healthcare workers. We don't want to go too far and obviously take it way out of context if people are doing things that they wouldn't have done otherwise. But if they're harming our workers who are there to provide care, then they need to be held accountable. And that's what we're trying to do here is we're trying to take all the steps that we can take to protect our nurses and our docs and everyone else in the facility.
Thank you. Okay. Seeing no further questions, DJ, please take the roll.
Representative Bratcher. Representative Bray. Representative Burke.
Yes.
Representative Callaway.
Aye.
Representative Camuel.
Yes.
Representative Dotson. Representative Fleming.
Aye.
Representative Gordon. Representative Holloway.
Yes.
Representative Marzian. Representative Neighbors.
Yes.
Representative Proctor.
Yes.
Representative Rayburn.
Yes.
Representative Raymer.
Yes.
Representative Riley. Representative Sharp.
Aye.
Vice Chair Duvall.
Yes.
Ranking Minority Member Wilner.
Yes.
Chair Mosier.
Yes. Okay. House Bill 713, as amended by the committee sub, passes with favorable expression. The same should pass on the House floor.
We'll see if the leadership will put on consent
Yeah,
calendar.
we'll work with them.
I wish
All
we
right.
had that. Thank you, Madam
Thank
Chairwoman.
you.
Thank you.
Okay. All right. Next, we will hear House Bill 676. Representative Raymer, please make your way to the table. And any guests? I believe, is Christy Putnam with you? There you are. You were hiding behind the post. Welcome. Please introduce yourselves for the record. And we do have a committee substitute. I need a motion. We have a. Okay, well, roll call having been called for by two or more members, we will approve the committee substitute by roll call. DJ, please take the roll.
Representative Bratcher. Representative Bray. Representative Burke.
I'd like to explain my no vote.
Yes, ma'am.
Receiving a substitute at 11:16 at night, not having it available for the public is extremely problematic. I want to be in support of this bill, but this isn't the way to do it.
Representative Callaway.
Aye.
Representative Camuel.
No.
Representative Dotson. Yes. Representative Fleming.
Aye.
Representative Gordon. Representative Holloway.
Yes.
Representative Marzian. Representative Neighbors.
Yes.
Representative Proctor.
Yes.
Representative Rayburn.
Yes.
Representative Raymer.
Yes.
Representative Riley. Representative Sharp.
Aye.
Vice Chair Duvall.
Yes.
Ranking Minority Member Wilner.
No.
Chair Mosier.
Yes. Sorry, I was choking on my water. Okay, the committee sub is adopted. Please proceed.
Thank you, Madam Chair. Representative Rebecca Raymer representing the 15th District.
Christy Putnam, Senior Policy Advisor for the Speaker's Office.
Okay, thank you.
Okay, House Bill 676, as amended by the committee sub, establishes a statewide health data utility. which is designed to securely aggregate health data so policymakers and patients can better understand how our health system is performing. As we know, Kentucky spends billions of dollars each year across Medicaid, insurance, employer coverage, and public health programs. Yet the data to evaluate those costs, quality, and outcomes is often fragmented across many systems. This bill creates the infrastructure needed to responsibly analyze the data so we can identify gaps in care, reduce duplicative services, and improve patient outcomes, and make better policy decisions based on the evidence. I think we're all here in the Health Committee because we want better health outcomes for our state, for our population, and the way we get there is we need better data to make better informed decisions so we can make those good policy decisions. I think that the committee sub strikes a good balance in housing this infrastructure within the LRC. This is a nonpartisan entity where this information will be housed. They would have this information available to all members of the General Assembly. And I'm happy to answer any questions.
Motion on the bill.
Okay, we have a motion and a second, and Representative Wilner, you have a question.
Thank you, Madam Chair. Thank you, Rep. Raymer. You're right, we are here because we want to improve public health, and we're all committed to that. I have no doubt. And I voted no on the sub because I really love the original bill. And so I was sorry to see the changes. And two items in particular, honestly, having it housed within LRC, I don't care where it's housed as long as we're getting good data. So that's not a deal breaker for me. But I was really sorry to see us do away with the consortium of public health colleges. That seemed to me like we're really bringing the experts together in this very, not even bipartisan, but nonpartisan way, like our public health data should be. So I don't know if, I guess the question is, would you possibly be open to restoring that makeup of the oversight committee and having that consortium from the 4 public health colleges in the state represented?
So, you know, we talked a lot about that, and I did like that university piece. We actually had more universities reaching out, wanting to be a part of that. So instead of naming the universities like we did in the original, we left it open-ended. We left language in where those relationships and that partnership can still happen. We just didn't name the universities because, honestly, I didn't want to exclude anybody that wanted to be a part. So the way the language is now, that can still happen. It can just be done through regs, through the LRC. Do you want to add to that?
No, that's absolutely right. It's not intended to preclude any of that relationship. It's intended to encourage a larger relationship with university partners because we recognize the value of that.
Thank you, Madam Chair. And thank you for the response. The additional heartburn I have about this is that I think in the sub changes the implementation from mandatory to optional. And that strikes me as problematic because what we would want it to be mandatory so there's a constant steady flow of data being collected and we're not sort of picking and choosing, oh, well, now we need data about this. And because data collection is a long-term longitudinal project. And so I guess I'm curious why you changed it from mandatory to optional and if you would consider changing that back.
I'll take that one. It was not intended to keep it from happening. It was intended to give the authority without being prescriptive over how the timelines happen, how the process happens. But the intent is for this to be an LRC function and give them full authority to develop it.
Thank you.
Thank you. Representative Camuel.
Thank you, Madam Chair. And I communicated with you that I really liked the first version of the bill so much better. But I was actually very similar to what Rep. Wilner was asking. If we don't have stakeholder participation, and I understand what you have said about what the language intended to do, but I worry that it will still limit participation, and I'm wondering if you would be amenable to adding some of the more stricter language back in so that we are getting good information, we are getting good data from all parts of the state, because in the end, this is what I believe it will help us make decisions in the future impacting access to care across Kentucky. And like I said, I'll make myself available to sit down and talk anytime.
Thank you. I'm honestly, I'm not opposed to having those conversations going forward. And as we all know, things change as they move through the other chamber. But it is absolutely the intent of this bill, and I think of the LRC to do these duties. We were just honestly trying, like she said, to give them the authority and the autonomy to do it. So, but I do understand your concern.
Okay. All right. Well, seeing no further questions, DJ, please take the roll. Representative Fleming.
Boy, I tell you what, I got to wash myself with the chairwoman. I just want to just mention to the committee, and I thank the representative and Ms. Putnam. This is going to, what I envision by having this in the LRC, it's going to be combined with the data sharing under House Bill number 2. So even though they're a little different, they will definitely complement each other in order to try to get more robust information so we can have a better understanding in terms of changing the policy and looking at funding mechanisms. So I just want to make that comment. Thank you.
Thank you. I do appreciate that you said that, because this has long been our goal to collect data, and I think we are all coming to a point where we really understand that we need accurate data to inform the policy decisions that we make here. So thank you for working on this. Thank you for bringing it. And thank you for the committee substitute. I know that you worked hard and fast trying to get this together. The reason being, the sponsor did not know that I was going to ask for this so soon. And but I really feel like in order to get this through, we need to work on it now. And so we're open to, and the bill sponsor has indicated that she's open to having any further conversations. To anyone who wasn't quite sure what this committee substitute did, I think we've had a really good discussion here, and I feel pretty clear. So thank you for your openness to working with folks. DJ, please take the roll.
Representative Bratcher, Representative Bray, Representative Burke.
I'd like to explain my vote. Thank you, Chair. I hope we can get to a yes. For me, the biggest sticking point between the committee sub and the original is the composition of the board. I thought that the initial board was drawing in such vast expertise. And this new board is pared down in such a way where I think we're really creating blind spots when we don't need to. And so I hope we could adjust that in the final version.
Thank you. Were you a yes or no?
I'm a no, thank you.
Thank you.
Representative Callaway,
Aye.
Representative Camuel,
May I explain my vote?
Yes.
Thank you. Today I'm a no, but I'm actually emailing you right now so that we can talk about ways we can improve it, and I can get to a yes on the floor. So thank you.
Representative Dotson, Representative Fleming,
Aye.
Representative Gordon, Representative Holloway,
Yes.
Representative Marzian, Representative Neighbors,
Yes.
Representative Proctor,
Yes.
Representative Rayburn,
Yes.
Representative Raymer,
Yes.
Representative Riley, Representative Sharp,
Aye.
Vice Chair Duvall,
Yes.
Ranking Minority Member Wilner.
Brief comment, please.
Yes, ma'am.
I'm a no for today, but I really hope to get to a yes, and I look forward to the follow-up conversation. So thank you.
Chair Mosier.
Yes. Okay, House Bill 676, as amended by the House Committee Substitute, passes with favorable expression, and the same should pass on the House floor. Thank you very much for your work.
Thank you.
Okay, seeing no further business to come before the committee unless Representative Fleming has something to add, we will be adjourned. Thank you.